We know that heart failure poses a particular burden to the healthcare system. Older patients with high morbidity have high levels of rehospitalisation and mortality. We also know one of the strategies to reduce that is heart failure management programs, and these in the form of home-based intervention, for example, can reduce rehospitalisation and mortality. But we're challenged now by these more difficult patients, and so heart failure management programs have to change. It was in this context the WICH-2 trial tested the hypothesis that a more intensive management program guided by a risk assessment program looking at high risk, low risk and low risk patients where we can do less with more to reduce hospitalisation. In order to test this hypothesis, we had a multi-centre randomised controlled trial. So we randomised approximately 800 patients across 4 centres in Australia to either standard management, the gold standard heart failure management, or a more intensified program of management. And these patients included those the more difficult with highly complex problems, and also patients who live far, far away from services. So these were regional dwelling patients who typically challenge heart failure management programs to access them and to improve health outcomes. So the outcomes from a trialist point of view were disappointing in the fact that there was no difference in the primary endpoint of healthcare costs at 12 months between the intensified management program and the standard management program. The only statistical difference was the cost of heart failure management program itself. Now that makes sense because we intensified management, we spent more money initially to manage these patients better, but ultimately there was no difference between the groups. There was also no difference in mortality, 18% mortality in both groups at 12 months, and naturally enough, there was no difference in the overall type of hospitalisation or even the subtypes of cardiovascular related hospitalisation or for heart failure related hospitalisations. For clinical practice, this means that standard management, gold standard management, if someone lives in a metropolitan region, that a heart failure management program that applies a less is more approach will actually achieve the best outcomes in terms of reducing hospitalisation and mortality. If a patient's living further away, cannot access a specialist program, that structured telephone support should still be applied. But we're left with this challenge that we're getting an increasingly older, complex patients who will challenge who do we manage better with these programs? How do we actually reduce their mortality and morbidity in the future? So as commented upon with this trial, we need a paradigm change. We need to think about the multi-morbidity. We need to think about how we utilize these programs in the future to reduce healthcare costs. If we don't, healthcare costs are going to go up and up and up, and they're going to challenge our healthcare system and basically bankrupt the system unless we get it right. The segue of this trial is we need further research, but we need to do it differently. We're certainly working on a program looking at the multi-morbidity in heart failure. So heart failure itself conveys about 30% of the rehospitalisation and the mortality. So that leaves us with about 70% in these patients that we're not managing as well. That includes things like anemia, renal dysfunction, they may have cognitive impairment. So these things contribute to the high recurrent hospitalisation and mortality. So new research, new programs are needed to prove which type of intervention gives us the best bang for our buck, if you like. Who are the patients we need to target, and can we actually reduce their morbidity and mortality in the long run?